My name is Cassandra Snyder-White. I'm an 8th semester nursing student here at Lincoln University, and today I'll be talking about a chest tube, how it was inserted, educating the patient's family due to my patient's sedation status, and asking any questions or answering any questions that the family may have. So this is Jimmy. Currently, he was in a car accident yesterday that resulted in some chest trauma, so he has some bleeding in his chest cavity, his pleural space. So he's currently intubated and sedated in the ICU with a chest tube. His family is now here and wondering what the heck this thing is on the floor that's got blood in it and why he has it. So I'm going to go ahead and do some education on it. So Jimmy was in his car accident yesterday, and during that he sustained some kind of chest trauma causing bleeding inside of his chest. So a physician took, this is called a chest tube, he took a chest tube and he inserted it by putting the catheter inside of Jimmy's pleural space, which is right about here, right about nipple line, and this is draining blood out of his chest. That way he can breathe better, because if there's extra blood inside the chest, then his lungs cannot inflate and deflate like they're supposed to. The physician anticipates this to be in for a few days. 2 to 3 days is about normal, sometimes a little longer, sometimes a little less, kind of depends on the patient. We check every day via x-ray to make sure that the chest tube is in place and that it's doing what it should and that it's draining the fluid adequately. And then all of us, the nurses, Jimmy's nurses, are in here monitoring the chest tube, looking for signs of infections. We're monitoring his respiratory status and his vital signs, and making sure that he's not developing any kind of complications. So the chest tube is composed of 3 compartments. We've got a drainage compartment here that is draining the blood out of Jimmy's air cavity. As the nurses, we come in, we mark after every shift with our name, initials, and the time about how much has been draining. So if there was some kind of situation where there was an excess amount of blood that drained all of a sudden all at once, like 500 cc's in 30 minutes, then we would probably be kind of concerned if there was not a circumstance that could have initiated that, like initial insertion or a lot of position changing. Something like that might indicate that, so we would continue to monitor, but we'd want to call the physician if it continued to drain excessively like that. This is our water seal compartment. So this is filled up to the 2 centimeter mark initially on its insertion. And what I'm looking for here in this compartment is what we call tidling, just kind of like a wave in the ocean. Whenever Jimmy breathes, it should go up, and whenever he breathes out, it should go down. If there's any kind of bubbles in this chamber, I would want to be concerned that there's some kind of leak, whether it be around the initial insertion site or within the tubing somewhere. This chamber alone just kind of prevents backflow of the already drained drainage back into the tubing and into the chest cavity. Then we have the suction chamber. This can be either wet or dry suction. Dry suction is simply suction connected to the wall. Jimmy has wet suction, so this is filled to 20 centimeters here, as well as connected to the wall, and this is just encouraging the drainage through the tube and into the collection system here. So this is actually on the floor. For video purposes it's not, but it would actually be on the floor. I've got the little legs kicked out here, and it could be taped to the floor. As the nurse, I would want to monitor that this tubing is in a dependent position, that it's not kinked, it's not under the patient, that there's enough line there, that way the patient can be repositioned and move. I would also be assessing the insertion site for any signs of infection or crepitus. So you want to physically feel around the insertion site for air pockets in the subcutaneous space. And then you want to monitor for anything like warmth, purulent drainage, swelling, redness around the insertion site that might indicate an infection. And like I said earlier, I'm also monitoring his respiratory status routinely and his vital signs. If he was awake and not sedated, I would want to make sure that he knows that he does not to get up out of bed without assistance, and that he needs help repositioning in bed, just so that we can make sure that this chest tube isn't pulled out. Whenever the physician does come to pull out this chest tube, or the nurse, whoever has him that day, needs to be ready with an occlusive dressing to go ahead and put over that insertion site. That way air is not let back into the chest cavity.